assessment, we're going to review the anatomy of the skin. When we're talking about the changes related to aging, we're talking about there's going to be a change in the turgor and elasticity that makes it more apt to be in damage. You have higher risk for sloughing or shear injuries. Patient history is also going to play a part. Certain allergies are more apt to have pruritus and urticaria, which are skin changes, which is itching and hives respectively.
Right.
Certain medication usage makes the skin more susceptible to damage from the sun and other external sources, making it more apt to be in damage via whatever it might be. Hygiene aspects, people with poor hygiene have more at risk for changes to their skin and integument system for not removing pathogens and all that wonderful stuff. So when we get down to the skin assessment, what we're going to be looking for is looking for any irregularly shaped discoloration or making note of where any moles are or anything like that. That way when you have further evaluation, if there's any change in shape or size or color or texture, it's noted so that they can be referred for additional care.
Okay.
That's what about it. For hair and nail, you're going to be looking at brittleness. Is there alopecia present, which could be an underlying, if they have like patchiness of the scalp, it could be a sign that there's a dermatological condition of the scalp.
Yeah.
So,
Okay. That's good. And I guess the main thing here is that you all, when you're out doing your assessments in the hospital, when you're checking your patients and you're doing your physical assessments, you're looking at all and asking all of these questions, right? And when y'all do a physical assessment, when you're looking at the skin, that's what, I mean, you look at the skin, right?
mm-hmm.
And you make note of things that are on the skin. So, y'all have to know how to assess the skin. All right, one of the things I just want to make mention of here, just because it's information that I think y'all need to be aware of, in the sense of personal hygiene. A lot of these disorders, you know, sometimes it can relate to, like he said, not taking a bath, okay, whenever they get stuff on, all right? However, I want to tell you about, you mentioned the older population. You know, as we age, you know, the immune system itself declines. But so does the mind on a lot of these older folks. And when I think about personal hygiene, I think about how a lot of older folks, when they come into the hospital, they don't look like they've had a bath in a week or two, okay? And some of them may not have. And sometimes it's because they can't reach over and wash their feet or their bath or whatever. It's a reason for that. And another is sometimes their cognition, they can't remember when they had the last bath, so they just don't take another one. You know what I'm saying? So you just have to be mindful of that when you're doing assessments and you're looking at your patients and you think about their situation. And if you know, if you see they have a cognitive issue, then that might be why they didn't get a bath often enough. Okay? Just a thought. Okay, now.
Pressure ulcers.
Right.
They're localized damage to the skin and or underlying tissue that usually occur over bony prominences as a result of long-term pressure, shear, or friction. The most common places that they happen are your sacrum, coccyx, heels, and hips. They also can affect elbows, knees, ankles, the backs of your shoulders, and the back of your head.
Okay.
Most of the time it's going to happen to the people at risk are going to be your elderly,
Yeah.
also immobile people or people that have poor mobility that can't independently turn over or lay on one side all the time or whatever. And to assess it, we're going to do the braiding scale.
That's right. Very good. Okay, so just to kind of reiterate what you were talking about, people that are at risk, we talked about the elderly and how their immune system is, you know, declining. So they are more at a risk. And the braiding scale, of course, y'all had that before, right? So y'all understand about that and how we do skin assessment based on that. So y'all good with that? Okay, now let's talk about the pressure ulcers themselves. Now, who has that? First and second?
The main thing is prevention, to prevent these things with the elderly or people that are immobilized and can't move. You can suspect the injuries, like it shows your skin's still going to be intact, but you might have bruising or pools of blood, blisters, stuff like that. That's where the turning schedule is so vital and important, and making sure the skin is properly cared for, stays moisturized, because if it gets dry it can split, or if it's too wet, if you're not changing their soiled linens, they can cause skin breakdown. At the beginning, the skin will be intact, but then, you know, there's red marks on it. That's, like I said, with the turning schedule. If they're lighter skin, it may be red, and if they're darker skin, it says blue, red, and purple, but I've seen it more of like the grayish tone, the blue.
Okay, yeah.
Kind of like a dusky color, and it's not gonna change colors when you press on it necessarily, but it's vital to know the signs and symptoms and make sure if they're immobilized to continue to help them move so that it doesn't get worse.
Okay.
Because when it goes to stage 2,
Stage 2 pressure ulcers. So at this point, skin's not intact. You're gonna have partial thickness loss, and it is usually superficial. Like Carrie was saying, on stage 1's turning's important. Once you've actually gotten to the point where the skin is not intact, you definitely have to adhere to the stage 2. At this point, also, you want to start using creams and moisture barriers more than before. You can get away with the Integument on the stage 1, but on these, you need to cream around them. Do not use powder because it can cause more damage to the actual wound. They're normally characterized by an abrasion, a blister, or a shallow crater. It just kind of looks like the skin's getting washed out at this point, but it's not all the way down in there yet. There's normally not bruising because the whole etiology of this injury is that there's no blood flow going to it, and that's why the skin's dying. Stage 3, though, you're going to have full thickness loss, sub-Q tissues may be damaged or necrotic. This is where it actually starts looking more and more like a wound. You could maybe let a stage 2 throw you off guard, think they just brushed against something. At this point, we're breaking down into the skin, and it's not exposing bone or anything, but it's a sizable wound at this point. And stage 4.
Okay.
you have anything to add?
I was gonna add on stage 1, whenever you notice
Okay.
the redness, that's where you really wanna start monitoring it, and like he said, putting a clear barrier down to monitor to see if it's getting any worse.
Okay. All right. Now, y'all think a second about your pathophysiology of the skin. When you think about your, and this is a review, guys. Y'all had this in level 2, unless you weren't here in level 2, and then maybe you didn't, and that's why we're reviewing it. But with, when you think about the skin, you got the epidermis, right? So you're really looking at the epidermis when you're thinking about stage 1, right? Because that top layer has not been broken yet. And then whenever you get to stage 2, the skin's not intact, but it's still like a partial thickness area. And what part does that go down into? The dermis, that's right. It's starting to go down into the dermis. And so then when you get to stage 3, then what? That's getting even further down through that dermis into the subcutaneous fat. All right? So you kind of see the progress there. And it's not down to where, like you said, the bone or the muscle's not exposed yet, but it's getting close to where that fascia does cover it. All right? And they may have, in stage 3, they may have that undermining. Y'all know the tumbling and the undermining? It happens there a lot in stage 3, and you'll see that. All right? Who has 4? All right?
Stage 4, it's mainly like skin loss. The skin loss is fully exposed to nerve. You can see like the muscle, the tendon, and the bone.
Right.
It often includes undermining or tunneling.
Okay.
It's the same thing. The sinus tracts may develop the slot and the discharge. They're often present and normally like at the least part of the limb. So.
Then there's unstable, which is, it's skin loss with full thickness and base is completely covered with the slough and eschar, so you really can't see or tell the depth of the wound. You can't see. 'cause
That's
the
right,
eschar
it's
is
covered with like that eschar on the top, so you can't stage it because you don't know what's underneath it. That's right. Okay, now you see where stage 4 has gone where bone, muscle, tendon may be exposed. It does definitely have most often that undermining and the tumbling. And then like I say, the unstageable, it's because you can't see under there to be able to stage it. All right, who has this one?
We did.
Okay, all right. This is just a picture that shows you the different stages, because you all are gonna be taking care of people like this. Are y'all okay over that? Okay. You're gonna be taking care of folks like this, and you're gonna have to be able to look at these folks and determine whether or not they have a stage 1, 2, 3, 4, okay? And then, of course, the unstageable, which you can't see. So, y'all can see the progress of that, right? Everybody good with it? All right, so how are we gonna care for these people that have pressure ulcers? You got that?
So we'll use the pressure relieving devices, which are just the specialized mattresses, the water bed, overlays, the frequent repositioning. We need to turn them every 2 hours. Inspect their skin, so look for the bony prominences, any red areas, any just like on their bottoms, look for areas where they've been laying down, on their backs, on their scapulas. Clean their skin soon after soiling, so they don't need to be sitting in urine or poop, because it can affect their skin and cause more pressure. And then gently pat the skin after bathing. You don't want to cause any extra friction because their skin is already easily manipulated. And then a high calorie and high protein diet, because it needs to be promoting wound healing.
That's right. Okay. You were heard, right? Okay. Now, was this one of yours? This is this one. Okay, can I back up just a second then? I don't want to get ahead of where y'all at, but I'm gonna tell y'all a few things about this slide I think is important that you remember. Like she talked about, you want to minimize the force or the friction on the skin so that you don't make it worse, okay? And she made a really good point of saying that you've got to clean that skin as it needs it. You can't let somebody lay in that urine or that diarrhea or whatever the case may be. Because y'all remember, there's 2 things that we have to do to prevent these pressure ulcers. All right, one is to keep them mobile or keep them turned, right? And the other is to keep them dry. Because if they lay in that urine for any length of time, then y'all know what happens as a result of that. So always clean them at the time of the incident. Don't let them lay in it. All right, also, y'all remember we talked about you don't want to really massage a lot, you know, on these bony prominences, or, you know, where they're having these breakdowns, because that might could make it worse, right? Okay. How do we as nurses take care of these folks who have, you know, they mentioned earlier on, where do they get these pressure ulcers? They get them on these bony prominences, right? So when you're taking care of your patients, how do you position your patients that are not real mobile to prevent them from getting pressure ulcers? How do you do that? What helps with that? Wedges, pillows, did you say? Okay, those are the kinds of things. Maybe, what would you do for somebody that, well, wedges may help with this, but what else can we use for the heels? Like if you see people, those heel pads, or those boots, or, you know, there's different stuff out there. And that's when we have our objectives, and it talks about these therapeutic devices and all that. That's why we bring all this into our objectives and why we talk about this, because it's important for us to know, you know, we're doing these things to prevent problems. So keep that in your minds about why we do what we do. Okay, now the nutrition's next. I want to get to that, okay?
Alright, things influencing wound healing. One is nutrition. Successful healing depends on adequate intake of calories, protein, vitamins, minerals, and water. Deficiency is common amongst the chronically ill, which leads to increased risk for skin breakdown and decreased wound healing. Something to check with that is your albumin levels. Anything less than 3.5, it will put some at risk for slower healing. Pre-albumin is less than 19.5, puts them at risk. You want to put them on a high protein, high calorie diet. Tissue perfusion, as with most of the body, poor perfusion can lead to risk for damage and ischemia, particularly with the wounds. It's, older clients do not heal as fast as younger ones. There's a decreased inflammation response and proliferation. There's reduced skin elasticity, and there's slower collagen replacement. And systemic disease can also delay healing, such as diabetes, mellitus, cardiovascular disease, which can cause poor perfusion, along with anemia, HIV/AIDS, which makes them more susceptible to infections, and pretty much any debilitating disease causing bed rest, prolonged bed rest. Infection can inhibit wound healing because bacteria can form a biofilm on the wound surface. Wound infection is a state of critical colonization of organism growth, and spread cannot be controlled by the body's immune defenses. You're going to see redness, inflammations, maybe some exudate and some odor. And then the infection could spread and invade deeper, causing bacteremia and sepsis.
Okay. See, that's a lot of information right there on that slide. You know what I'm saying? So y'all just make yourself aware of that, how important nutrition is, how important it is to make sure they don't lay in one spot for too long and they don't perfuse well. And if they get an infection, you know, who's more susceptible to that? The ones that, you know, are in bed like that, and the ones that usually have some of those comorbidities, if you will, and their age, of course, and the systemic disease would be some of those things, like you said, diabetes or whatever that would, you know, they would kill as well. That was good, good job. Okay? Do you have the one on the different devices? Who has that one? Did I not give that to anybody?
You did say you was gonna have to do a couple of them.
What?
You did say you was gonna have to do a couple of them.
Well, I guess I'll do them. Okay. I thought I had a card on that, though. That surprised me. I have to have my cards back, by the way. Okay?
We had that card, I guess it was out of order.
Oh, you did?
Mm-hmm.
Well, talk to me about it. Come on now. That's an easy one.
I mean, I guess it's pretty self-explanatory. You can just use different types of beds, if the hospital permits, just to keep some pressure off of the already formed pressures.
Okay. Well, y'all, this is just, like you said, this is what is available, and y'all have an objective that speaks to you about these devices. So we have to speak to those, and y'all know you use them, in the hospital. We're talking about the heel floats and, those using pillows and all of these things that might help. But we also have specialty beds. We got water beds. We've got these different kinds of mattresses. What is that one they put on top of the bed called the,
Like a gel?
what, don't let me. It's like an egg crate. It's an egg crate. Okay, y'all know what I'm talking about, that we put. That's an overlay to me, you know what I'm saying? So that's what that's referring to. We're trying to get some way to prevent these people from getting pressure ulcers. Okay, that's the whole point of this. Now, I want to talk to you just a bit on help taking care of these folks. All right, you all as nurses are responsible for these people's care. All right? But you can't do everything for everybody. So you're going to have some help by some of these unlicensed people. All right? So y'all need to make sure that you understand what these folks can do and can't do as it relates to helping you take care of these people in whatever situation they may be in, but they're going to be there. And I want to ask you some specific questions. All right, can an unlicensed person assess? No, they cannot assess. All right. Can an unlicensed person put any medication on a patient? No, they cannot.
Huh?
What? They can't put meds on.
Topical.
No, not meds. Not if it's a medication. They're not supposed to be allowed to put a medication on. Okay?
Okay.
They can't even put a lotion on a patient who has an open wound. You know what I'm saying? If there's an open wound, which these people have, they're not supposed to put anything on. That's my point. No meds for sure because they're not licensed. It doesn't matter what it is. Okay? And their role is not to assess. Okay? They can go report they see something, but that's not an assessment. Okay? Now, let me think of what else. What can they do? Like a nurse assistant, what can they do? They can turn them. They can turn them. Right? They can bathe them. Right? But when they do that, what, I guess we just need to make sure we understand, first of all, they're supposed to use gloves, right? Okay, when they're taking care of patients. And they, we always talk about hand washing being the #1 way to prevent an infection. And you wash your hands between changing gloves. But my point here is, if you have someone who is not licensed helping you take care of a person who has a wound, they can't put anything on that wound, okay? They're not really supposed to even wash that wound, right? Don't look at me funny, man. Isn't that right? Are y'all following me? I don't know, you don't act like you agree with me.
When I work in wound care, Hibiclons, barrier creams, that's why I'm I'm shocked because I've been told that's my job too.
Okay. All right. I'm just telling you that whenever you think of the role of the individual, a nurse assistant is not to give or apply medications, regardless, okay? They're not gonna assess that wound. They shouldn't be cleaning that wound, okay? Okay. I'm just saying, personal care is personal care, okay? You can bathe intact skin, right? Okay. All right. Moving right along, skin cancers. We got a lot to cover, short period of time. Okay, who's got the first skin cancer? Go ahead.
Skin cancer with actinic keratosis. That's caused by years of sun exposure. It's rough, scaly patches, usually yellow or brown in color, and it can progress to squamous cell carcinoma if left untreated. Basal cell is usually the most common, and it can be confused with psoriasis or eczema. It rarely metastasizes.
I know there's somebody that's gonna be talking specifically about these. She's just introducing them. It's the
But it
introduction
still
slide.
causes tissue damage. It can be genetic predisposition. They're usually small, waxy nodules with central ulceration. Squamous cell, it can start as actinic keratosis, and it does metastasize. It looks like actinic keratosis with thick, rough, scaly patches, and usually other signs of sun damage. And melanoma, it's highly metastatic. It's a pigmented cancer, and it usually starts as a mole, and that's where the ABCDE comes into play, especially. And if anybody doesn't remember what the ABCD is, it's the asymmetry, the regular borders, color, diameter, and evolution.
Okay. And we'll probably be reviewing that again, okay? All right. Who has this one?
Oh, that would be me.
Okay.
So, we have skin cancer, health promotion and maintenance. Prevention is avoid and reduce skin exposure to sunlight, avoid direct sunlight, wear sunscreen, wear protective clothing, avoid tan beds. Also, if you're wearing a sunscreen, reapply it frequently, at least every 2 hours when outdoors, especially if you are sweating or in water. Try to get water resistant products. Also, early detection, keep the body now from skin spots and lesions to detect any changes. Seek medical advice for any changes in skin lesions. Monthly TSSE, I still haven't found out what the TSSE was. And then of course she read off the ABCDE. Risk factors are incidence in highest among light skin races. People older than 60 years of age, and I did find some more risk factors. Personal history of skin cancer are precancerous skin lesions, tendency to freckle or burn easily, lots of sun exposure throughout your life, many sunburns as children or adolescents, a family history of non-healing wounds or burn injuries, radiation therapy, exposure to toxic material, exposure to certain subtypes of human papilloma viruses like HPV 6, 11, 16, and 18. They've been known to become squamous cell carcinomas, especially in patients with compromised immune systems. And organ transplant patients, I really know that on, suppressant drugs, they have an increased risk of skin cancer as well. Let's see. Also, people who work outdoors in higher altitudes or lower altitudes. And like I said, spend a significant amount of time outdoors.
Okay. All right. So basically, that's the risk factors that people may have as it relates to getting skin cancer. That's what it's telling you, okay? And we had that, like I say, in level 2 as well, talking about like the higher altitudes, being closer to the sun, you know, working a lot outdoors and being exposed to different carcinogens in the environment. And you mentioned about the ways that people need to be taught how to prevent skin cancers and staying away from the sun, avoiding tanning beds, y'all remember that, and doing these monthly checks. And I'll find out what that TSSE stands for. I can't remember.
Thorough self-skin examination.
Thorough self-skin assessment. Evaluation? Evaluation.
Examination.
Or examination, yeah. I couldn't remember that T. I kept trying to say, what is that T? Thorough self-skin examination. That's what it is. I knew it was, I couldn't remember the T. It was just killing me. Okay. And then y'all got to know, you know, about your A, B, C, D, E. And, you know, we use that a lot on the melanoma. You know, looking for different lesions to see, you know, if there's something that we might need to pick up on there. And that would be what? The A stands for what? Asymmetry. What's the D?
Border.
The irregular border. And the C?
Color.
Is that color variation, okay, within one lesion? And the D?
Diameter.
That's right, 6 millimeters, about the size of a pencil eraser. And then the E? Or changing in it, the size, the color, whatever, evolving. Okay? All right. So what about the actinic keratosis? Who has that one?
A lot of us have.
A lot of, well, she just introduced it. Tell us about it,
Do
Akia.
you want me to like go, cause everything I have is the same thing they literally.
Well, say it again. I want to hear it.
Actinic keratosis is pre-ligament lesions of the cell of the epidermis. It's common in adults with chronically sun-damaged skin. Lord Jesus. The description is dry, rough, and adherent yellow or brown skin. If left untreated, it can lead to progression of squamous cell carcinoma. It's highest among light-skinned race and people over 55, outdoor workers. They live in higher or lower altitudes. If they spend time sunbathing or their occupational exposure. Do you want me to do the preventions and assessments and the non-surgical interventions? Oh, I got a lot. Okay,
Say what now?
do you want me to do it like everything? Like say everything over? I don't know. I'm sorry.
Like, is there a slide for the treatments and stuff, or?
Well,
I don't wanna say
basically,
everybody's stuff.
and see, there again, a lot of this is repetition because it's used for different things, like the 5FU, I call it, but it's fluorouracil or something like that. It's a chemotherapy,
It's
a
the
topical.
topical chemotherapy. It's continued for several weeks. The treated areas are tender, inflamed, crusted. They ooze and they erode.
Okay, somebody has the one on medications that talks about the different meds. Now, there's a slide on that as we come forward to the topical chemotherapy, which is the 5FU, okay? And so we'll talk about that a little bit more when we get to that slide too, okay? All right, so we talked about the actinic keratosis, which is a precursor to a cancer, okay? But it's not a cancer, it's a precursor to it. All right, so what about the basal cell carcinoma? That is a cancer. Who has that one? Go ahead.
Okay, basal cell carcinomas arise from the basal cell layer of the epidermis. Early lesions often go unnoticed, and although metastasize is rare, underlying tissue destruction can occur. Genetic predisposition and chronic irritation are risk factors. However, UV exposure is the most common.
Okay.
It has a small waxy nodule that is translucent with curly borders. Crusting appears on the face. Recurrence is common, and the treatment is topical chemo or biotherapy with interferon and then the
Right. That's right. Now, 5FU can be given intravenously as well as a chemotherapy. In my younger day, I gave a lot of that for cancer patients that didn't necessarily have a skin lesion. But if they had the skin lesion, then that's what we used for them. And we use for the actinic keratosis, we would use the 5-FU for that, most often, all the time. But then occasionally, after they'd have a surgery or something to their basal cell or their squamous cell, then we might use the 5-FU after that, the topical. Okay? All right? So, there we go. That's pictures. All right? That shows a picture of the basal cell. And to me, I think it's the more, what did I do? It was a more translucent kind of cancer. Pearly white a lot of times too. That looks a little redder. All right, squamous cell.
Squamous cell is the cancer of the epidermis. It's a chronic skin damage from repeated injury or irritation. It's usually curable, but if left untreated, it can metastasize and be life-threatening if it spreads to lymph nodes or organs. A biopsy is taken to determine treatment. You can use the topicals or excisional surgery, laser surgery, or the chirosurgery. Symptoms: firm red nodule, flat sore with a scaly crust, a new sore or raised area on an old scar or ulcer, rough scaly patch on lip that may evolve to an open sore, a red sore or rough patch inside the mouth. And risk factors is fair skin, excessive sun exposure, use of tanning beds, history of sunburns, personal history of precancerous skin lesions, personal history of skin cancer, a weakened immune system, and if you have a rare genetic disorder.
Okay. All right, so of the two, the basal cell or the squamous cell, which one is the most likely to metastasize? Squamous cell. That's correct. And that's a picture of what they look like. Okay? And we're going to talk about the different types of treatment for these in a few minutes, but that's what they look like. All right, malignant melanoma.
Okay, on malignant melanoma, this is a malignant neoplasm in which atypical melanocytes, which are pigment cells, present in the epidermis. The risk factors are exposure to UV light, which is like a tanning bed. If you have a lot of moles, fair skin, freckles, light hair, a family history of melanoma, like a first-degree relative, like your mom, your brother, sister, something like that, but that is kind of rare for it to be running your family. A personal history of melanoma or other skin cancers, a weakened immune system, being older. It's most common in people who are 50 to 70, but they are seeing an increase in teenagers and younger adults. It's more common in males, and also if you have a rare inherited condition called ectoderma pigmentosum.
That sounds right.
Okay. It affects like how your skin cells repair themselves.
Okay.
And also, it's most likely to be found on the backs of men and the legs of women. It mostly affects the epidermis, but it can become thicker and involve multiple layers of the skin. It is highly metastatic, and the survival rate depends on early diagnosis and treatment. The survival rate is 90% of people diagnosed survive at least 5 years after they're diagnosed. The characteristics are it's irregularly pigmented, more than 6 millimeters in diameter. It's asymmetric, eroded or ulcerated.
The outline is irregular and it can be flat or elevated. And then on the assessment, like this is where the A, B, C, D, E is very important because these moles, they're gonna change. So you have the asymmetric, where the border has no particular circumference, irregular surface sites, and lesions are not balanced. So if it has like jagged edges or anything like that, the border, it can be irregular, fuzzy, it can be indented, jagged. The color is variated shades of red, white, and blue. 2/3 of the colors are abnormal because normal moles are usually brown or slightly darker than normal skin color. The diameter exceeding 6 millimeters is significant. And then if you notice that it evolves or changes in any way, you should get it checked out. That's it.
You were hurt, huh?
Yeah, I read.
All right. Yeah, y'all just pay attention, like the melanoma. I had a cousin died from a melanoma that she had a mole on her back. It was, you know, it's hard for people to see their own back, you know? And so, once that was evaluated, it had kind of gone a little too far. So it did metastasize very quickly. And she did die from it, some complications from it from the attack. So I know how serious this is. Okay? So that's why we do good skin assessments, and if anything looks funny like that, you want to always have a healthcare provider evaluate that. If you have a patient that you see something on their skin that looks like a melanoma. Okay? All right, now as far as the medications, let's talk about that for a minute. Who has that one? Okay.
The first one, it takes the therapy continues for several weeks. The areas that are being treated are going to become increasingly tender and inflamed, and it's going to cause lesions to crust, ooze, and erode. So you need to prepare the patient for that crusty appearance, I guess. The next one, the biotherapy, it is used for melanomas and stages that are 3 or higher. The patient first starts on a high-dose IV interferon infusion daily for 5 days per week for 4 weeks. And then they have to have maintenance doses also, and you're going to have to teach them how to self-inject the medication. The other treatments, the cryo surgery, cell destruction by local application of liquid nitrogen, causes cell death and tissue destruction. The next one is removal of cancer cells with the use of a dermal curation. What it does, it scrapes away the cancerous tissues, following by an application of electric probe to destroy the remaining tissue tumor.
Okay.
The next one is an excision, usually for basal and squamous cell carcinomas. The tissue is sectioned horizontally in layers, and each layer is examined, and it determines the presence of the tumor cell. And the last one is a deep skin resection. It involves removing the full thickness skin of the area of the lesion.
Okay.
And then they also may remove the lymph nodes.
Very good. Okay, so let's kind of review this one, just to make sure everybody's on the same page. Y'all need to know about the 5 fluorouracil, or however, we used to call it 5FU, so anyway, that's what we'll call it. Okay? And basically, what you need to know about that is that, you know, this treatment can last for several weeks. And what they do is they put that medication on that cancer, and it will look a whole lot worse before it gets better. And they do look really angry and really ugly. And I've used it, I've seen it. Have y'all seen it? It's really a rough looking lesion at that point. Okay, and not only does it affect that lesion and start causing it to erode, okay, and hopefully, you know, it eventually peel off and go away, but it affects that tissue surrounding it as well, and that can make that tissue very red and tender and inflamed looking. But what you're gonna see is that that's gonna eventually, it's gonna crust. It's real crusty, it's real oozy, and then it'll eventually erode out and go away. But I guess one of the good things about that treatment is that there's minimal scarring. These folks don't scar a lot from that, as bad as it looks, while it's eating away at that cancer. After it's done, there's very minimal scarring. And, you know, they may do some chemotherapy of another type, depending on what type of cancer they're treating. You know, a lot of times they just use it for that actinic keratosis, which is the precursor. I've seen it used for that a whole lot. That's the main thing. But then they may use it for a basal cell or a squamous cell after they do some of these type surgeries and things that she mentioned. Okay? So let me just go over those again. That cryosurgery, y'all realize, is that liquid nitrogen that they spray on these precancerous places. Okay? Then they do that curettage and electrodesiccation, and basically what that's doing is scraping it off and burning what's left. And then the Mohs surgery, that's the one where they take and they slice it. And they keep taking thin slices of the tumor, and they'll take it to the lab and see if it still has cancer cells in it. And once they slice it on down and they don't see any more cancer cells, hopefully they've gotten it off. And then the last one is that wide excision where, you know, it has metastasized to an area, and they will take as much as they can from that area and possibly go and take some lymph nodes that are near it. So, good job on that. All right, now, gotta move on. These bacterial, viral, and fungal infections. Now, where are we starting with that? Okay?
Alright, you got bacterial infections, which will be folliculitis, which is it's a super infection of the upper portion of the follicle,
Okay.
and it's usually caused by staphylococcus. It's going to be isolated urethral pustules occur singly or in groups. Hair grow from the center of many lesions. And then the next one's going to be furuncles or boils, and they're usually caused by the staphylococcus, but it's much deeper than the follicle. These are larger, sore-looking raised bumps, and may or may not have pustular heads. And then the last one for the bacterial would be cellulitis, which is a general infection with either staphylococcus or streptococcus and involves the deeper connective tissues. And on rare occasions, blisters are present. Then you have viral infections, which are herpes simplex, which is group vesicles are present on their erythemus base. Vesicles evolve to pustules, which rupture, weep, and crust. The lesions are associated with itching, stinging, or pain. And then you have herpes zoster, which is lesions are similar in appearance to herpes simplex and also progress with weeping and crusting. And the eruption is preceded by deep pain and itching. Secondary infection with necrosis is possible. And then you have fungal infections, which is dermatophytosis, which is annular or serpentitious patches, which is like snake-like wave movements. And then it's itching is common. Lesions may be simple or multiple. And then you have candidiasis. Yeah, that's the white stuff in your mouth, antibiotics.
Okay. We're going to have people talk about all those. He's just giving an introduction. Okay. All right. That was just kind of an introduction to this, okay? And who has the nursing care of patients with skin conditions?
Main priority for us is to prevent any additional damage from the infections. It's also to prevent secondary infection because most of them will either have open wounds, be immunocompromised, so they can easily get a secondary infection. You want to reverse any of the inflammation by medication medication administration. That will also help get rid of the bacteria and the fungal. We also have antivirals for those too. And relieving symptoms, that would be like creams, lotions, also more medication. And then like the nursing care is administering the topical and systemic medications, doing wound care regularly, checking the dressings, making sure the patient knows how to clean it, hand hygiene, and then teaching the patient about what's going on, what's their disease process, how to prevent any further damage. And then if it's bad enough, it could cause like skin breakdown. They could have what's it called? Like the way they look.
I'm sorry?
I like body image.
Body image issues.
Oh, gotcha.
Yes, they have body image issues, so talking to them and providing support with that is helpful.
Yeah, okay. All righty. Now, this is what, he mentioned about the bacterial skin infections. We gotta move along, guys, okay? On the different types of bacterial skin infections. Like we talked about, you've got the bacterial, you've got the viral, you've got the fungal. Okay? This is some examples of some of these bacteria. Y'all wanna talk about that? Okay.
Like A is impetigo, B is like the furuncle, and the last one is cellulitis. And they're all bacterial infections. No treatment is antibiotics, topical antibiotics. You want to prevent the spread by hand washing, good hygiene, make sure you don't share any personal items. And that's what I got for the patient education. We just want to make sure that they're washing their hands all the time and not sharing anything to spread it. And then I have the MRSA.
Okay, well, let me go back for just a second. Just as a matter of information, when you're looking at these bacterial skin infections like the folliculitis, you know, what you need to think about there is that's follicles of the hair, wherever, okay? And that's what that is. And one of the things that we have to worry about with that is secondary infection. Because if people start scratching, you know, as a result of that, then they end up with a secondary infection. And sometimes people have hair loss as a result of it, okay? So keep in mind, scratching can lead to a secondary infection. Okay, when it comes to your cellulitis, you need to remember to measure, like they've got the little line right there. Keep in mind that you need to measure that so that you can have a baseline and determine whether that's getting worse or not. Warm compresses, they say, can help with comfort as far as the treatment, you know, for the cellulitis. Warm compresses I put down would help for that. Use water-based creams and things on issues like this rather than something that would plug up the pores even more. You know what I'm saying? So you don't want to use anything that might have a lotion or a paste on these situations. Does that make sense? Water-based. Okay. Now, MRSA, she's going to speak to us about that.
It's spread by contact, so as nursing considerations, you want to make sure you use disposable gloves, wash your hands frequently. You're using contact precautions. And when you're teaching the patient, you want to teach about washing their hands frequently to prevent the spread. And they don't need to be participating in any sports. They want to avoid close contact. Want to make sure they take all their prescribed medications. Keep the infected area, like if it's a wound, keep it bandaged with clean and dry bandages.
Okay. Well, y'all taking care of patients with MRSA, right? Y'all know how important it is to keep them hands washed, okay? Not share things, all right? One of the things I want to make mention here, you know, it's contagious, right? Okay. Going from person to person, you can transfer that. All right. I want to mention the vancomycin. All right. Nobody had that, right? Okay, I'm going to mention. All right, vancomycin is one of the medications that we give, you know, to treat MRSA, and y'all probably given some of that by now, okay? And what is one of those side effects that we watch for if that vancomycin was maybe given too fast? Do you remember what that's called?
Nephrotoxicity.
There's a name for it. Red man syndrome, okay? It's called red man syndrome if they happen to, it's a histamine reaction to giving that vancomycin too fast. And what is something that we need to watch for when we give people vancomycin? What's a common thing that can happen as a result of giving this strong antibiotic? Okay, think of something that we'll watch for that we could see possibly.
Urine?
Okay, think of thrombophlebitis. Okay, that's one of those issues that goes along with vancomycin, is thrombophlebitis. And we have to make sure that we observe for any kind of inflammation, even around the site. You know what I'm saying, where they're giving the IV? Because you can have, just like inflammation, you can have the red, swollen, painful, you know, area around where you have your IV site as a result of vancomycin. Think.
Infiltrate.
What else? Y'all just, you know, just review that on your MRSA because you need to know about that, all right? But just remember thrombophlebitis as it relates to monitoring your IV when a person's on vac. All right, moving right along. Impetigo.
Okay. Impetigo is common in children. Begins as a reddish macula and becomes vesicular. You get the honey-colored crusts. It's a type of staph. It's very contagious until you're on treatment for 24 hours. Once you're on treatment for 24 hours, it's no longer contagious. It's auto-inoculable, so if you touch it and touch anywhere else on your body, it's going to spread, similar to warts. And the medication for it is the mupirocin, although it's contraindicated to use around the nose and the mouth, which is more commonly where kids are going to have it. In that case, they have a nasal version, or also oral penicillin, and if it does involve to MRSA, then they go on vancomycin.
Okay.
And things to look for afterward, teaching hyperpigmentation in occurring kids, and it's very rare that it's going to become systemic, but there is the chance that it will become systemic. And once you've had it, and it's cured, it's not going to come back unless you come in contact with somebody again. It's not like a virus that you're just immune to.
Yeah.
And the big things with it is hand washing, and just don't touch the stuff. And if you apply the medication, use something clean to apply it, and don't reuse it.
Yeah, like a Q-tip or something maybe?
Yeah.
Okay, that's what I was thinking. All right, so it is very contagious. And the next one, I'm sorry, did you have that one?
Yeah.
Okay, because I didn't move it on over. But y'all can go back and read all of this on that. Manage it with soap and water. And they got Bactroban here. What did you say?
That's the brand name for it.
That's what I was wondering if it was, because I'm not.
Mupirocin is the generic.
Say it again?
Mupirocin, M-U-P-I-R-O-C-I-N.
Mupirocin. Okay. All right, so y'all, I'm still trying to catch up with all these generics. But anyway, y'all remember though, oh yeah, it talks about a Q-tip here, using a Q-tip. But just keep in mind good hand washing on any of this kind of stuff. It's always going to be good hand washing. Okay, what about, well, there we go. Who's got that? All right.
So the focus for this is going to be the prevention of spreading. So you want to teach the patient to not share personal items like their hairbrushes, clothes, or shoes. You want to teach them to bathe daily with an antibacterial soap and to not squeeze any boils or pimples. The drug therapy that's used is going to be topical antibacterials like penicillins or cephalosporins. So teach the patient to gently remove the crust before they apply these medications so that the drug's able to be easily absorbed. And teach the patient, like you said, to apply the warm compresses as well to increase comfort.
Okay. All righty. So, tell me what some signs and symptoms of infection would be.
Fever,
Okay,
raised white blood cells,
all right. So you've got, fever, what else? Purulent discharge,
Redness, tenderness,
pain. Don't forget pain, guys. Yeah, the tenderness. You know, we say tenderness, but sometimes that's an indication that a person's getting an infection if they start hurting, right? Y'all don't forget that. And they could, like I say, they could still, like you mentioned, they could have some purulent drainage there. But what else are we going to observe for?
Swelling.
Okay. Have some swelling and pain. All right. And we can have some drainage. What else would you see a change? What else might change?
their attitude maybe,
Okay.
their demeanor.
Okay. I'm looking for one more thing. I'm looking for something else that you might see in a person that has an infectious process going on.
Odor? Like a change in their mental status?
Okay.
No.
That could be. I mean, it's for how severe it is.
Well, their labs are gonna change.
I'm talking about like the actual wound itself. The actual wound itself. We talk. All right, y'all listen to me now. Y'all told me that it can start hurting. That's an indication.
It'll get bigger.
There you go. You got it. The size will get bigger. It won't shrink. Right? It can get bigger in size. That's what I was looking for. Because when you start thinking about a wound that gets infected, that's the three things that I'm going to think about. First of all, they're going to have some pain. Chances are. They're going to have maybe some drainage from that, purulent drainage. And the third thing is that size will start getting bigger. Okay? So, to me, that's important. All right. Y'all, I know we're running out of time here, but what we have coming up is our oncology coming up, and we can steal some time from that because we need to cover everything. All right? And we have next week, and I'm thinking that oncology is on the next test, so you're better off to get the rest of this than you would be to stop and have it on your own. You know what I'm saying? So, y'all want to move on, or y'all need a little break and come back? What's going to do? Huh? Break?
Yes, ma'am.
All right, take your 10-minute break, come back, we'll finish up this, and then we'll touch on the oncology.
I know, Dr. Brown needs to get off.
My goodness.
Have a seat.
How old is she?
What'd you shake that?
Negative.
Did they shave it like a clothes razor, or did they shave it
I mean, I did on your site, but we don't want any harm.
Whenever you go all surgery, you can shave
Well, that's what we'll have to tell her. You gotta know she's taking care of it. She's like, you don't have to worry about it. All the time. Have to go on and do
That's what that.
And they're not.
Yeah.
Well, you have to go by that.
I had to mix the piercing.
mentioned that it could not go to my days, but I had to go to the medication and it will tell you time started, last administrated, all that stuff. Any labs. What is your There got some like the yeah, I find out.
So we got him. We've had him for 3 weeks now.
Yeah, well, usually I
Weighed like 7 pounds. Where's the vet Wednesday? He is like almost low down.
I don't doubt it. Anna hit like 25 pounds at 2 months.
Really?
Like super fast. Like she's 35 pounds now. Today she turns 5 pounds.
I'm like, how much everyone?
Honestly, they tell us between 45 and 50 pounds. And she just keeps getting bigger every day. And loves to eat.
Like, he's in this room.
I was like here 3 times a day.
Yeah.
But then I get so old, I'm not gonna hurt.
She had curly hair or straight hair? Curly. I think he's got straight hair.
Yeah. But I think I'm better than like I do like it.
Let's check it.
She she's like the best.